Thank you very much, Professor Oak. It's my great pleasure and great honor to talk about this the new device for the challenge aortic arch pathology. Different pathology, different anatomy of the whole aortic arch. We do need individual treatment. Just like Professor Oak emphasized, some cases we still need hybrid procedures. But some cases, for example, just like Professor Stephen Chang described, it can totally done by endovascular technique. It's very skilled. We emphasize, of course, we have different kind of method. Just like Professor Stevenson emphasized, we can use a pan stent graft with my device, Longate, manufactured by Naptech company. We can also perform the fenestration. Also, my patent, the C-skirt, the whole string graft system in aortic arch for in situ fenestration. We can also use the branch stent graft, including the single branch, double branch, and triple branch. The data in 5 hospitals, we find it. Every year we have more than 200 aortic arch endovascular procedures. But we can find it, the ratio for the branch stent graft increased every year. Then the fenestration technically reduced. So why? Because the branch stent graft, if it works so well, so everybody like to use it to release the operation time. The single branch nowadays are in China are most commonly used is a caster. We do know that caster is well accepted in different countries. I also use a caster device to perform the Chinese case in more than 15 countries. Every case gets a very good result. For example, such a case is very simple for you to do it, use a caster. But we have to emphasize, as you release the caster, you have to listen to the heartbeat. It's very important because at the beginning of the heartbeat, the blood pressure is very high. So it's easier for the caster to migrate. Also, the small curve, thank you so much. The small curve drop into the end rhythm of PAU. If it's the end of the heartbeat, the blood pressure is very low. So this time, it's more safety. So we also use the caster to treat the acute and canonic dissection. It seems like it works so well. For the canonic dissection, you can also use a balloon to balloon the coarctation area to get a very good solution. So this case already done TIVA before in another hospital. Then he come to me. So we can use a caster pass through the first stent graft, then to deploy inside to the LSA, and plus elongate the chimney stent graft to the left carotid to rebuild 2 branch vessels. This case, the total operation time is only 1 hour. It's very quickly, no complications. Especially to the aberrant subclavian artery, we can also use this device to rebuild. So to the end rhythm near the aortic arch, we already use the chimney plus caster. It means that we use a caster plus elongate stent graft to treat the patient to rebuild the left carotid and LSA. This procedure is very simple. It's very quickly for you to do it. So we already finished such kind of cases in 10 countries. The result is perfect. The long-term result, all the carotid artery keep pattern, but a few cases, the LSA, for example, just like this case, because the severe angulation exists, the stenosis. So that's a case we have done with a caster to rebuild, caster plus the longate to rebuild 2 branch vessels. We have done a lot. We already published 2 papers talking about this technique. We also get a long-term follow-up, more than 5 years. The results perfect. Now, we'd like to talk about, just like Professor Stevenson emphasized, the allowable show Chang. It's my name, sorry. So we I invented this device just according to the fenstration. Just like I talked about yesterday, I have more than 15 years experience for table fenstration. Based on the table fenstration, we designed this special sling graft. At the beginning, we give the special name Super China, but it already restricted by others. So we have to change the lane to be sure chain like this way. So the tip of the branch sling graft is very flexible. It contains about 5 millimeter to 1 centimeter. The angle is very flexible to adjust, just like Professor Stevenson emphasized. Also, the bridging stand is very flexible, especially the protrusion side is special design. Also, the delivery system is pre-curved. So you may find it here. So you may find it. The delivery system here is a very, very special design. Here, the pre-curved. Then here, the tip already contains a caster inside the standing graft. Then we can, that's a bridging stand, the resistance is very flexible, just like Stephen emphasized. As compared with other device, the bridging stand is very, very flexible. Then here, you may find it here. So the special design can prevent the endo leak. So we can deploy the pre-curved the device into the aortic arch. Then we release the outer shift. So this time, this caster contained inside the standing graft, like already fenestration, can jump into the branch vessel. So what it means? It means you need only one puncture area of femoral artery. So this caster from the tip to the end, you can adjust it. Then you put the caster inside the branch vessel, then put another valve. The special design valve is 3 meters long. From the femoral artery go inside to the LSA. Then you totally release the standing graft. So this time, you retrieve back the whole delivery system. Then from the valve inside to the LSA, from the femoral artery, you deploy the bridging step. So it's very quickly for you to do it. So this special design, compared with the TBE and caster, no kinking. So you can go directly to the aortic arch. Also, it's more simple, only one exercise. So we have done a lot in China. It's a multi-center investigation from the beginning to the end. I know Professor Fu Jia is also come here. He also uses device like Professor Stephen Chang. All the cases we have done get a very good result. To the whole cases, we have the follow-up. So that's why in China, the multi-center investigation, just within 10 months, 135 cases finished. So all the data are sent to the CFDA. The government gave me the information. Maybe this device will be approved, get approval very soon, because the result is perfect. So we have done a lot for all the cases. We have all the data. You may find it, no matter acute aortic dissection or type 3 aortic arch, no matter acute or chronic, even the PAU, so it's much better for you to use this device. No matter how severe angulation of the branch vessel, also just one exercise for you to do it. So that's all the data, you may find it totally done by the Chang, this special single branch device. The most quickly operation time for us to do it, from the first angiogram to last angiogram, only 9 minutes. The longest operation time for the newcomer to do it, 1 hour. So it's really accepted by the local doctors in all different centers in China. And that's all the cases to be done by this new device. All the cases has a very good result. Only one patient suffered from heart attack after 1 month. Another case suffered from mild stroke before discharge to the hospital. But anyway, the patient recovered back so well. So all cases get a very good result in the finding. All the cases, we have the follow-up. That's totally the multi-center investigation to 1 kg and 35 cases. That's a very good follow-up. So totally, we'd like to emphasize the 13-day mortality is very low because just the 1 case suffered from the heart attack after 1 month later. Another has a mild stroke but recover back. No paraplegia, all the bronchial vessel keep pattern. The best advantage of this device is much simple for you to use it because the pre-curved, the design of the resistance, also the caster as you release outstrip is easy to jump off inside to the LSA. Also, you can rebuild the left carotid like this way. So let me talk about another device. Just now, I'd like to thank a lot for Professor Stephen Chang. He has used this graft so experienced to fit the challenge cases. So this concave supernal, the 3 branch vessel reconstructing device is my patent from 2011. So we do animal study for about 10 years. Lastly, as my assistant can perform the animal case, 1 morning, 2 cases, then we begin clinical study. So this is why special design, the concave design, can you see here? The bell stand, the first edge is non-absorbable, but the second edge, this one is absorbable. Also, this bell stand is very flexible. You can use a balloon to change the profile. 2 tunnel to the ascending, 1 tunnel to descending. The design is just want to preserve the bloodstream. So the bridging stand is very flexible. It's easy for you to deploy. So that's my patent 2011. We finished the animal study. Then till now, we've finished all the international multi-center investigations. So now all the data sent to the CFDA in more than 7 countries, including Germany, including Italy, including Greece, including even Venezuela. So in Stevenson's hospital, Primary, and other hospitals, everybody like it. No matter severe how challenging of this one, including the Switzerland. So we have done it very freely. The most quickly operation time for us to do it is in my center. The first angiogram to last angiogram, 32 minutes. The longest operation time for me to do it is 109 minutes. So that's why all my case, only 1 case suffered from mild stroke. The mild stroke, the patient no symptoms because in Fuai Hospital, all the cases has been reconstruction of the whole aortic arch will be sent to the CT scan by the ICU doctor. So my case, after he recovered back, the ICU doctor sent him to the CT scan. They find a mild stroke, but no symptoms. So that's all the cases. We have the follow-up. The longest follow-up is more than 4 years. The branch vessel keep patent. This is the first case we have done. The aneurysm we have done. It's easy for you to do it. This case, we spent only 55 minutes. So first, you perform angiogram. Secondly, you deploy the main body. Then you cannulate from the bronchial to go inside to the normal. You deploy the bridging stent, then balloon it. Then from the left carotid, you deploy the bridging stent, you balloon it. Lastly, from the LSA, you have 2 methods. One is from the mouth, one is from the femoral artery, you cannulate to the LSA. Another one is from the bronchial, go down to the descending aorta, then you deploy the bridging stent. It's very convenient for you to do it. It's very important that because the tip is very short, so we need a pacemaker. Every case, we need only control the blood pressure is around 100 to 120. So you can do it very freely. This case has been done by the local hospital. The newcomer can finish the whole procedure only 60 minutes. So I suppose Professor Hu Jia come here. He also done some cases with his device. It's very convenient. So that's our angiogram. Then we deploy all the stent graft, then perform the angiogram, no endo leak. So that's a very challenging case. That case, I have done it for 109 minutes. As a type 3 aortic arch, we have to use a snell to take the wire out. It's not so easy to deploy the bridging stent. We also use a kissing balloon to do it, to get a very good result. So that to the acute L dissection non-A non-B, it's very useful. So that's why I emphasize, just like yesterday, Professor Sung, you talked about the special case. So we can use the concave superconductor to do it very freely. So acute L dissection usage device, it's very easy for you to do it because you use the kissing balloon, then the whole true lumen can be totally open, not like canonic. Not like canonic. So this one, we deploy the main body, we cannulate, then we use a kissing balloon to open the true lumen, then to get a very good result. So this one is I'm sorry, it's a canonic, it's not acute. This one is also non-A, non-B because the patients, the suffered from L dissecting more than 3 months, then we do it very freely. But at the beginning, it still has the endo leak because the true lumen cannot be totally open. Then 2 weeks later, totally open. We use a kissing balloon, no endo leak anymore. So we have all the data of the patients. Till now, all over the world, we have 142 cases. We have all the follow-up. So that's the data, you may find it, no matter the type 3 aortic arch or type 1 aortic arch, no matter acute dissection or canonic dissection, or even PAU or severe angulation of the branch vessels, the result is perfect. So all the other data are coming to my center, so we will analyze, then publish the paper. We already published a paper for the film research. 10 cases with 1 year's follow-up is perfect. Then 142 cases, the follow-up till now, it seems like also very nice. Only a few cases, the LSA exists, the stenosis. So we also designed the special LSA stent graft to prevent the stenosis after deploying the bridging stent. So that's all the cases, you may find it. Some cases are very challenging, but anyway, the follow-up is perfect. So in a full-eye hospital, we have done many cases. My personal, I go to different medical center to perform concave supra is 45 cases. All my cases, no mortality. Only one patient suffered from mild stroke. So that's all the data that I have to show you. We also have the extension. For example, this one, during operation, you can add another extension. This is a shoot of the concave supra. So that's all the data, you may find it, very good result. No matter how severe angulation of the branch vessels, it seems like no endo leak. So that's all the data. So nowadays in China, the mainland, so we have the special device. We have the parallel stent graft to the aortic arch. We have elongate. We have fenestration stent graft C-skirt. We have ocular stent graft system for the self-radiographic physician modified fenestration. We have the single branch. We have Chang. We have Custer. We have tag. We have 2 branch vessel relay. We have reflow. We have Cook. Then we have 3 branch vessel reconstruction device. We have concave supra. So I do believe that no matter how, the whole aortic arch treatment will be in the future, I suppose. Maybe more than 18% of the cases can be done totally by endo. But anyway, open surgery and hybrid procedure is still very important. Just like Professor Oak emphasized, in China, it's the same situation, although the hybrid procedure reduced. But anyway, it's still very important to treat the patient. Thank you so much. Thank you.